Hello and welcome to Health Tech Builders. Here we explore the business of health innovation through real stories from leaders in the trenches, the wins, the failures, and everything in between. You will get insights and practical advice to help you build and lead in health tech. I am your host, Rodrigo Hute. Today, my guest is Julia Bernstein. Julia is the Chief Operating Officer at Brightside Health, an exciting and growing virtual mental health company serving patients in all 50 states. And it's also tackling one of the most pressing issues in healthcare today, which is access to high quality mental health treatment. Julia has deep expertise in behavioral health and digital health as well, having worked at companies like Ginger, Beacon, and Tempest. Today, Julia will be sharing with us her perspective on the current state of the mental health market in the US, also her experiences building and scaling Brightside, and also the realities of scaling digital health companies and everything, the good, the bad, and the ugly. So Julia, thank you so much for being here today and welcome to the podcast.
Thank you. I'm excited to be here and, share what I've learned over the last almost 15 years.
This is very exciting indeed. So Julia, for listeners new to Brightside, how would you describe the company? Who do you serve? The services you offer, etc.?
Yeah, so Brightside Health is a comprehensive provider of life-saving mental health care. We serve patients in all 50 states with a focus on really being able to address a wide variety of conditions, both in terms of diagnosis and acuity. We offer one-on-one therapy in psychiatry, a suicide prevention program, and now an intensive outpatient offering for both mental health and substance use. So for folks who are coming in with a mild to moderate anxiety and depression, we can absolutely address that, all the way through folks who, might be one step lower than those who might need inpatient care. We serve those who are 13 and above in most states, all the way through to the Medicare population. So it's a very broad age range. And we're able to take coming on almost about 170, 180 million covered lives. And so folks can use most major commercial insurance, most Blues plans. We take Medicare and Medicare Advantage in all 50 states, and we take Medicaid in a select group of states. And, I think that we are differentiated not only by our suite of services, but also by our real focus on quality. The company was founded by a psychiatrist, a tech entrepreneur, and a product guy. And from the beginning, we've come at this with a perspective that access is necessary but not sufficient, and it's really about quality. And so how do we build Brightside with the right systems and technology to enable clinicians to provide quality care and help patients get to the outcomes they desire?
Access and quality, absolutely, you need both. Would you say anxiety and depression are main conditions that you treat?
That is, I think, the majority of folks who come in, but we see, in addition to that, everything from bipolar disorder to substance abuse issues to, a lot of co-occurring conditions co-occurring diagnoses alongside anxiety and depression.
All right. And how do you measure success? What kind of KPIs do you see yourself discussing in board meetings?
Yeah. So, I think our North Star metric has always been to deliver life-saving mental health care. And so, we're looking at where are patients from a severity perspective, where they can't come in, how quickly do we get them to, a decrease in severity, and then how quickly can we get them to remission? And so, first and foremost, from a quality perspective and an outcomes perspective, that's what we're holding ourselves to, and that's what we're hoping to deliver to our patients. And then all of our other metrics, whether we're looking at cost savings for our payer partners, we're looking at how quickly we can get patients into care, we're looking at what's the experience of a provider on our platform. We're looking at some of the more financial metrics. It all stems from that. What matters most is that we're getting patients better, and we're getting them better in, an appropriate period of time with long lasting impact.
And from a business model perspective, payers pay each time their members use your service. Is it on demand, or is it like a monthly type of fee that they have to pay you regardless of utilization? How would you?
Yeah, so we started as a cash pay subscription model. And so, there's still a percentage of our patients who are either uninsured or underinsured or choosing not to use their insurance that are paying a monthly subscription model. With the extent of the payer coverage, we have the majority of our patients are using us under a fee for service model. So very similar you'd see if you went to a therapist or psychiatrist in your town if they took insurance. So the patient comes in and they are billed for the encounter, and then the claim is sent to um, the health plan. And so kind of the majority of the US care system looks a lot like this kind of fee for service billing. Interestingly, we've started to move towards what I consider more interesting arrangements where the payers are paying for outcomes, the payers are working with us on, how do you pay for a bundle of care. So I think there's, some good initial progress there, and a lot of but the majority or signal for future investment. But the majority of our business is what I would consider fee for service healthcare. We're not, and this gets a little bit into market mapping, but we're not an employer focused player. So most of our relationships from a payment perspective are with the health plans. And then most of our patient acquisition is happening either directly through a relationship with the patient or through a referral relationship with another health system or medical provider.
I see. The market and the competitive landscape seems to be growing, and in my opinion seems to be crowded. So I really wanted to ask you, maybe you could give us like a simplified kind of market map of the mental health market, just for all of us to understand the many players. And at a high level, you have the traditional psychologists, psychiatrists with their physical practices, you have hospitals, and then you have the emerging virtual players. Is that kind of accurate? And then how would you describe everything that is happening within the virtual space or digital
Yeah,
space?
yeah, absolutely. So the first thing I would say is I actually think it's an amazing thing to be in a market where be in a time when the behavioral health market is crowded. If we think back to, 2012 when I worked at my first behavioral health company, you know, there was still so much stigma about this delivering this type of care. And there was also a lot of investor skepticism and payer skepticism that people would want to use these services virtually and that demand would continue to grow. So, while the market is crowded in the sense that we have a lot of entrants and frankly, new entrants come entering every day, I think the market is big enough and diverse enough that there's a lot of really compelling businesses to be built. When I think about the market, so as you said, there's sort of the in-person first providers that we're more familiar with, or traditional PE-backed, hospital system-backed, single shingle providers, and then you have this digital landscape. And I would cut the digital landscape really across, on two axes. I think the first is who are they selling to? And I think there you see the direct to consumer players who are going direct to consumers with a cash offering that tends to be a more mild to moderate population. You'll often see async prescribing or text-based care there. And then you have the folks who are selling into employers, which is more of you'll sometimes hear this talked about in terms of EAP or employee assistance program. And those are the folks who they're going to Boeing or they're going to Amazon and they're saying, hey, you want to provide 4 free therapy sessions to your clinician, to your patients. We're going to work with you. And, Ginger, where I started my career in behavioral health, which is now part of Headspace, is a classic example of someone who's been selling into the employer market, although they also have other revenue streams. And then the third bucket is kind of where Brightside falls, which is an in-network provider that has, deep insurance coverage, working with a number of health plans, and we allow patients to use their insurance benefits to cover care. So there's sort of the payment access, and then there's the what they actually treat. And so you have sort of a spectrum of from what I would consider point solutions that are treating a single condition. And there's some really interesting businesses there. If you think about the average cost of care for a patient with eating disorders or a patient with opioid use disorders, and some really interesting companies that have gone very deep. And then you have sort of a number of companies that have an increasing breadth in terms of what they treat, both in terms of acuity, but also in terms of the conditions. And so I would put Brightside on, this part of the spectrum where we are both comprehensive in what we treat and in terms of deep in terms of the severity that we treat. And then, there's probably a third cut, and I'm changing my access to a grid here, but that is who they treat. And so you'll also have folks who treat pediatric, who do, adolescent, who do adult, who do geriatric. And then, if you want to get even deeper, there are companies that will only do women's mental health with a focus on the fertility journey. You'll have companies that do Asian American mental health. And so, I think we just did a market map with a group called Second Opinion Media led by Chrissy Farr, and it was not me-see. There were companies that were in multiple places because Brightside does substance use addiction or an alcohol use disorder treatment through our IOP, but then we also treat Medicaid. So that puts us in two different categories. And so, it's a crowded market, but it's a complicated one with a lot of opportunity.
Absolutely. It doesn't seem to be clear cut, but
Yeah.
I really liked your explanation. Made it clearer to me. And I really like the first axis, the payment axis, direct to consumer, employers, health plans. And as a follow-up, I wanted to ask you, do you see differences in quality and outcomes if I am a patient with mid or severe anxiety or depression, and I go to a DTC company or an employer-based company or a health plan-focused company? Have you seen evidence that patients' outcomes are different?
Yeah, it's a good question. I think behavioral health treatment is incredibly personal, and what works especially when it comes to, when you look at medication, it's actually quite hard to titrate. There's a bunch of different SSRIs. So should you be on, Zoloft, or should you be on one of the other medications? So, medication can be incredibly hard to titrate. What's the right dose? How do you avoid side effects? And I think therapy is also very deeply personal. So it's hard to make blanket statements about a single platform or even a single type of platform. What I can speak to is how, quality has become an increasingly important part of the value proposition of any provider, regardless of what type of care you're offering. And so, when Brad, Mimi, and Jeremy started Brightside, measurement-based care, which is kind of what you're asking about, which is how do you actually measure quality, was really, really core to what we do. And so we have 8 years of outcomes, and we can stand behind, over 80% of our patients see real improvement in the 12-week period, and we can use that to, build and strengthen our relationships with health systems and health plans, and build consumer trust. And so we have that data and that story and that conviction, not only that we have delivered those outcomes, but that we can continue to deliver those outcomes because of the way we've built technology-based decision support for our prescribing and a more standardized protocol for our therapy. What's been really interesting to see is over the last 2 to 3 years, everyone else is investing in measurement-based care and quality and making it part of their story as well. And so, again, it goes back to, during COVID, all that mattered was access. You couldn't get access to care. Everyone was struggling. You needed to get people into care. And I think we kind of came out of the COVID era and we're like, okay, it's great. Like, we have all these players who have who can get you access. And it's still not easy. And the more specialized your condition, the longer the waiting list. But if you need to see a therapist, there's a half dozen platforms that take your insurance and you can see a therapist. And so now it's really about how do we get you to the right therapist on the right platform, and how can we demonstrate that, this is measurement-based care and that we're able to deliver quality. And so, at the end of the day, it's better for patients because now patients have an experience that's grounded in a desire to measure quality no matter where they're getting care.
So how does Brightside define quality nowadays? I would imagine that it has been an evolution, or is it still the same?
So it's been an evolution. I think and it's been an evolution not just for Brightside, but for the entire industry, especially when you're dealing with something as subjective as behavioral health. And then you're also dealing with the dynamic where, interestingly, therapists and psychiatrists were actually left out of a lot of the meaningful use regulation in the early 2000s. And so the behavioral health industry didn't have the funding for a lot of the data-driven work that a lot of other specialties did. So, at Brightside, we started with, I think, where a lot of companies start, which is using these evidence-based scales. You might, if you've ever kind of gone through an intake and you've been asked, are you having trouble sleeping, or, do you regularly feel worried? That's a question from the PHQ-9, which is a validated depression score, or the GAD-7, which is a validated anxiety score. And those are sort of the gold standard. Are your patients getting better? Then you have the cost metrics. You're looking at claims, you're looking at how many appointments someone is having, how quickly we're getting them better. And then you're looking at sort of more functional metrics as a patient reporting that they're feeling better, or they're getting more joy in life, they're better able to engage. We've evolved our thinking beyond these initial metrics. And so one of the things we actually put together last year, and maybe we can link to this in the show notes, is Brightside's mental health quality scorecard, which is a 40-point scorecard that looks at what it means to be a quality digital provider. Not only outcomes, but how secure are you? How ethical are your business practices? How good is your customer service? Because if you think about a behavioral health patient, every interaction they have on the journey to care really does contribute to the outcome. So it's something we've been thinking about and looking at, defining not only in terms of sort of the black and white clinical outcomes, but the entire experience of being a behavioral health patient.
Very interesting. Yeah, so it's a combination of a clinically validated questionnaires with the cost data and all of an access, and so that makes sense. I would imagine that differences in quality also have to do with the providers, the type of providers, and the experience of providers, the mix of experiences of providers, and the treatments that they implement, and so on. With so many companies out there, would you say there is a talent war, like people fighting for the best talent, and would companies like Brightside hire these physicians and specialists to be part of as employees, W-2s, or are they more on demand? Or talk a little bit about kind of the supply side of those dynamics.
Yeah, I mean, it's definitely something that we talk a lot about, and when we talk about our mission as an organization, one of our goals is to be a place where therapists and prescribers want to work. I think, again, if I look at sort of the crowded nature of the market, or just the growth in the market, what's really interesting is clinicians now have not only a choice of platforms to work on, but they have a choice of ways in which they can work. They can still work independently, and they can, decide to do everything brick and mortar, or use something like a Doxy or a Zoom to just do HIPAA compliant sessions. They can decide to use a marketplace company that provides back office services, but doesn't necessarily provide, supervision and marketing, so that, they're running their practice, they're called, it's a managed service organization environment. And so you're basically running your practice on someone else's back office, but you're still an independent practitioner. You can choose to practice in a 1099 model where you're giving some number of hours a week to a platform that is itself a provider of services in a clinic. And that's where you have, if you're a NP or a PA, you might have your supervising MD is set up for you, and you're going to have training and you're going to have support and quality. And if you're on the therapy side, you might have something like Brightside's unified protocol, which is a suggested way of practice that you can choose to incorporate into what you do as a contractor. And then the kind of final model is a W-2 model where someone's working part-time or full-time for a platform. These are not mutually exclusive. You'll often have a provider who's like, 80% of my private practice is cash, and then I take insurance patients through one of these marketplace models, or I'm a 1099 on a platform like Brightside, or you might even have someone who is a W-2 and doing a few hours a week in private practice. So what's really nice is we've created kind of this choose your own adventure structure. And so there's a lot of ways in which therapists can work. Workforce management and workforce strategy is one of the biggest things that I spend my time in and have learned a lot on over the years. And so, we feel good about the structure we set up at Brightside, and, are really focused on continuing to make Brightside just a great place to work in terms of the level of support we're able to provide, the tools and technology we provide. Don't underestimate how important having a purpose-built EHR for behavioral health is, and then making sure we have the right program managers on call if someone needs a consult or if someone needs help. And so trying to make something that can sometimes be a very independent role more community-based.
I've seen that the industry has made a ton of progress, and I think that's very positive, especially over the last 5 years. But I also see that major challenges remain, and I would like to mention a few of those to see if you would agree. But on the one hand, there continues to be huge demand, and people are, as you talked about, the stigma and all of that, but there is still a lot of unmet need. On the other hand, there is still, you were talking just now about, staffing issues, like finding the right talent, experts, providers. Long wait times, still remains an issue in terms of access. Reimbursement gaps, you also touched on that. Younger populations also emerging with a big gap in care, I would say. And also, I've also heard a lot of, payers and health plans, asking for more evidence in terms of ROI and outcomes and so on. Would that be a kind of a comprehensive list? Would you add anything else to the list of challenges that mental health companies are facing nowadays?
I think you've gotten a lot of them. I might say that payers asking for clear ROI is not a bad thing. I think it just is work we all have to do. But yes, those are things that I think about and talk about on a daily basis.
How's Brightside working on improving some of these challenges? Maybe you can pick a couple on.
Yeah, so I think it's interesting because there are the challenges that I can address, and there are the challenges that I can't, or not can't, but that are more external. And so I think a lot of what we've talked about in terms of focusing on both access and quality, making sure that we're a fantastic place for clinicians to work, really trying to make sure we have a great platform set up. Those are all very core to what we do. If I look at the KPIs that I hold myself accountable to, in addition to really being able to show outcomes, the next one is timely access to care. And so making sure that our patients can get care in a timely manner, and to make sure that they can then get follow-up care in a timely manner once they establish the therapeutic alliance with their clinician. And I think and the other big one is continuing to expand our payer access so that more people are able to use their insurance and can be kind of what I consider almost payment agnostic here. So I think those are, a bunch of things that we're looking at. And then, you mentioned youth mental health. We've launched our teen program, which was a deliberate decision to expand to meet what we have seen as an unmet need. I think a couple of the things you've named are more really regulatory challenges. And so we've done, a limited amount of lobbying, looking at some of the things we've seen around Medicare and Medicaid regulation, substance use treatment regulation that may or may not affect our business. But, we've been focused on what are the things we can control, and then how do we create, environment momentum around some of the more, industry or system level changes.
So you touched on the wait times or access to care. What's your goal? What's your objective? How long does it take for someone to get access, and how does that compare to, what's the industry benchmark? Just to get an idea.
Yeah, so the industry benchmark, can be anything from 3 days to 30 days to 90 days, depending on where you live and whether the therapists or psychiatrists there take your insurance, or whether you're trying to get into an eating disorder treatment program with a wait list. And so I think we all have the stories of, like, you call your PCP, you get a referral, you call the clinic, they don't have it's September, they don't have an offering until January, so they refer you to someone private pay. And then, I can keep going. I think we've all had that experience if you've interacted with the US healthcare system. We hold ourselves to a standard of being able to offer every patient an appointment within 48 to 72 hours based on their insurance and where they live. But, we really want people to get care immediately. And interestingly, we introduced a same day booking feature, which was something we did with a lot of conversation with our clinicians, because if you're a clinician, you're working multiple platforms, an appointment pops up in 3 hours, you want to make sure that you're available and that you have time to review the patient charts. But, even that has been, I think we've been pleasantly surprised by how much uptake we've gotten for even those same day initial appointments.
I love it. I think that's great. Let's shift gears a little bit, and I want to talk a little bit about technology and AI and digital tools.
Yep.
So could you name 2 AI or digital initiatives that has really moved the needle at Brightside, whether it's, for clinical outcomes or improving your unit economics? What has been your experience with that?
Yeah, absolutely. I'm impressed we've gotten this far without talking about AI yet.
Yeah.
Yeah. So I think we've spent a lot of time thinking about our AI strategy as an organization. And I think we are coming at this from the perspective that, the most immediate use cases of AI are not clinical. They're clinical adjacent, or they're administrative. And so, we are certainly interested in continuing to use these emerging technologies to support care with a human in the loop. I think every day I'm forwarding a headline from the Wall Street Journal or the WAPO or New York Times to my team around someone's upset about ChatGPT as a therapist again. So none of these examples are that. I would say, 2 interesting examples. One is clinically, what I would consider kind of clinically adjacent or clinical enablement. So we introduced a proprietary transcription tool for our clinicians earlier this year. It's double opt-in. The clinician has to consent to transcription of the encounter, as does the patient. And then we use that transcription to auto-populate notes for the clinician. And then the data is deleted, and anonymized within 7 days. And so that's been a huge help for us, both in terms of, giving our clinicians, the confidence that transcription is happening, allowing them to be very present in the moment, and then allowing them to cut down on their administrative time through note taking. So that's been a big win. And, I would say, probably not surprising, I think transcription is quickly becoming table stakes in medical care. And then I would say on the administrative side, we've been doing one of the things that's become an increasing part of the way we interact with patients is managing both referral in as health systems and other providers say, hey, you'd be better served by going to Brightside. But then also as a patient comes to us and they have an eating disorder, they need inpatient care, we need a place to send them. And so, as you can imagine, curating a referral list for all 50 states and every demographic and diagnosis is incredibly complicated. And so we've been able to use ChatGPT and a number of tools to put in place a much more efficient workflow that's taken my care coordinators, from half an hour per referral to 5 to 8 minutes per referral. And so we're still able to do right by our patients and be connected into the broader healthcare system, but we've been able to do so in a much more efficient way. So, you know, lots more examples like that, and I feel like we're still just scraping the surface. But I've been really excited about what we're seeing, and the other thing I'll say about the second example is that one came from my team. We said to them, figure out how to do this more efficiently, and they worked with our data and tech team and put that one together, and that to me is really exciting.
That's exciting indeed. So mainly non-clinical workflow automation. That makes sense. What's your opinion on the clinical side of things? And also, there is one of the things that I believe that patients really want. It's empathy and compassion.
Yes.
So what's the role of AI, in your opinion, for clinical decision making and for helping providers being more empathetic, compassionate with patients?
Yeah, so I think there's a lot of what I would consider clinician support tools that build on, frankly, a lot of what clinicians are already using in terms of clinical decision support. Or, if you look at what a company like Headspace has built, they have all sorts of nudging tools when a coach is working with a patient. So I think there's a huge opportunity to just get better and better at the clinical decision support to help a clinician, double check they've selected the right medication for a patient, or, to give alongside your screen as you're doing an appointment, a couple of nudges. Hey, their intake indicated a history of trauma. Did you remember to ask about it? There's some interesting companies that have been focused on voice, not only voice AI outbound outreach, but, measuring emotion in voice. And so I think like there's all of these ideas. I think the question is, how do you integrate them into practice in a way that supports but doesn't replace the human? And then, the other question, especially this early in the technology cycle, is who pays for the use of those tools?
Do you see a medical super app in the near horizon, in the near future? Or do you think it's still going to be years until doctors, providers have access to a supercomputer to help them make better decisions? And it's a very broad question because it really depends on the
Yeah,
specialty, but what's your take on it?
I think that doctors already have access to tools they probably couldn't imagine having 5 or 10 years ago. And so I'm not sure I can predict what the next 5 to 10 years will bring. But yeah, I mean, I was at a healthcare conference a couple of months ago, and one of the CEOs who was presenting, said the question she is asking her team is there anything you're doing the same way today that you did 2 years ago, and why, and how could you do it differently with AI and a lot of these new tools? And I think that's the question all of us need to be asking ourselves, not only with how we do our day jobs, but how we empower clinicians to do their day jobs. And so if I knew the answer, I'd probably be off writing checks, but I do think it's an important question, and I am cautiously optimistic that we've got some really smart minds thinking about what we can do with these tools, but how do we stay true to, the need for empathy, the need for outcomes, the need for oversight. This will gets into, how do you measure quality when it's an AI? So I think there's a lot of both business and philosophical questions to answer.
What other companies other than Brightside have you seen have you seen building a truly impactful digital tool or digital therapeutic or a or an AI platform to support in mental health? Are you, yeah, what would you say? What's been your experience there?
Yeah, I mean, I think it's too early to speak to the efficacy of sort of the new AI chatbot therapy programs, but I think there's so many interesting companies that are being built, not only the tech-enabled services companies like Brightside, but infrastructure software companies. So, for instance, I'm an investor in, and we use a revenue cycle management platform called Candid that serves a lot of behavioral health companies. And I think, rev cycle is not the sexiest part of the healthcare industry, but being able to make sure people get paid is really interesting, and it also allows behavioral health providers to do everything we do. And then there's a lot of interesting applications of AI, again, either as a digital therapeutic. My daughter's using a game called Mightier, which is a AI anxiety ADHD management game that they pair with a heart rate monitor. It's kind of wild. And then there's sort of like human in the loop AI companies. I'm an investor in a company called Marigold, which is an AI assisted peer support program for those living with substance use treatment, which is, the chat, but it's a chat with other humans and with, technology, but there's a human in the loop moderating the conversation, and it's a nice balance of that automation and that empathy.
I wanna switch gears again and ask you about kind of your go-to-market commercial model. And you mentioned earlier that um, your model it's around building relationships with health insurance plans, the payers. So could you talk a little bit about, could you describe like your go-to-market or commercial strategy or playbook, and what's working in nowadays in 2025? What's not working? What would you suggest, other emerging digital health companies trying to build relationships and with or contract with, health payers do,
Yeah. I mean, it's interesting because different tactics work at different times in the market. So when I started at Ginger, now Headspace, it was a lot more employer focused, and now the pendulum swung towards, table stakes as being in network as a fee for service provider, and then the opportunity is to improve your rates using your quality outcomes, which is a lot of what we've done at Brightside, to get to more pay for performance and, light value based contracts, which again is the path we're starting to go down at Brightside. And then even to kind of contract directly for a bundle of services, either day one or as you're able to demonstrate for outcomes. I mean, I think we're incredibly fortunate to have, a fantastic commercial team that's been focused on health plan contracting that, was able to get in network. And then once we were in network, to use the outcomes we were delivering to get better rates, better arrangements, closer arrangements. And so, I think that's a playbook that's become relatively expected, as you kind of like you launch cash, you get a little bit of money, you get a little bit of outcomes, you try to get a network as fast as you can with your key plans, and then you put your health plan sales team on improving those health plan relationships. Interestingly, we've started to diversify our commercial go to market, because even if you're contracted with a health plan, you still have to go get the patient. It's not like, maybe they're going to the website and you're listed on their website and a patient will come to you, but you're still doing brand marketing, you're still doing direct to consumer acquisition, you're still building relationships so that the patients are choosing you as their provider. And so we've been diversifying our commercial strategy to partner not only with health plans but health systems, to say to them, hey, this is no cost to you, but you have patients coming in who need outpatient mental health when they go home and your system doesn't do it, or you're a residential treatment provider, and your patient needs to go back to Arizona and needs an outpatient therapist or an IOP program. And so, being a referral partner to a health system while being a provider partner to a health plan. So, that's been an interesting path to go down. And I think, if anyone takes one of the themes of this podcast, I think, is just how complex all of this gets. And so, it can start straightforward as just a fee for service contracting relationship, but can quickly get quite complicated.
Yeah, it sounds like it's an evolution. You need to
Yes.
be, it sounds like you have to be in network and do the work to establish those relationships
Yep.
and then prove outcomes. And then you're also diversifying and having these other partnerships because what you mentioned with health, health, not plans, but the other term that you used was systems, the health systems as well. They can see you as a partner because they want to, they can see you as a partner, but they could also see you as a competition. So there is
Yes.
it can get a little bit complex and tricky.
Yep.
As you have been able to scale, and you mentioned that you are in 50 states, you serve patients across 50 states. What were some of the objections that were, that you guys faced in order to scale across states? How hard is to go from state to state? What lessons did you learn there?
Yeah. So there is a very, I'm going to use the word again, complicated regulatory framework around providing care in the US. There's something called a professional corporation, which is a standard legal model in a lot of sort of licensed professions. Plumbers use them, lawyers use them, clinicians use them. And what it basically says is if you are a business that is delivering medical care, you need to be owned by a licensed clinician. And some states will let you take a professional corporation that's headquartered in Missouri and use it in Texas, and some it's foreign register, and some of them will make you start your own medical group in that state. And so, the first thing is right from a regulatory perspective, you need to build your medical group, you need to build your corporate entity, which is providing services to the medical group. You then need to license and register your medical group in every state you want to practice in. You have to make sure the owner of your medical group is licensed. It's very complicated. The kind of good thing is enough people have done this now that there's a pretty standard playbook, but it takes time and money. And then the same way that your, your professional corporation may not be licensed or eligible in every state, the same thing applies to your providers. So so a provider who is licensed in New York can only treat patients who are physically in New York. And so you can cross-license folks. So you can say, hey, New York clinician, I'm going to license you in New Jersey and Connecticut, so you can see everyone in that region. And there are also compacts that say, hey, you're a psychologist licensed in New York, and you can more easily qualify in Montana. But you really need a workforce in every state that you're going into. And then that means you're modeling demand. And so, I often talk about managing a 50-state clinical network as modeling in 4 or 5D, because you're looking at where are they licensed? You're looking at which health plans are they enrolled with? You're looking at, do they have a specific specialty? And so, again, it can get a lot to balance the demand and the supply side across 50 states.
It sounds challenging, and it's not like the typical tech company that you see on the news scaling very rapidly. Here is like you have to go step by step, and navigating the regulatory hurdles as well. So, for example, so if Brightside, when you guys launched in California or pick any state, and you have to create a professional corporation, and you need to have a physician who owns a controlling stake of that entity. How did you navigate that? I mean, is it because Brightside is a company, you have different founders, you have investors, so how does it work?
There's a pretty standard model in digital health known as the MSO-PC model, where you set up the medical group, and then you set up a managed services agreement between the medical group and the corporate entity, and there's, the appropriate ownership rules. But, what it means is you have to be very, very clear around what the medical the medical group owns, and that is care. And so in some ways, like, it's incredibly it creates a lot of hurdles, but it also creates independence for the providers from the corporate entity, I think in a way that, really benefits the patient.
Yeah, yeah. All right, all right. So I wanna end this episode by also discussing your experience as an executive, and currently you are the chief operating officer, but you've also been like growing and scaling other companies. So I'm very curious and interested in learning from your experience. So the first question I wanted to ask is, what do you do as a COO in your first 90 days of the job? You come in, it can be Brightside or it could be another company, but you step in, you have the new job, the new responsibility. Like how do you structure your first 90 days?
Yeah. There's been a lot written on what to do in your first 90 days. From my perspective, it's not actually your first 90 days, it's your first 30 days, and then your next 30 days, and then your next 30 days. And so, having come in a leadership role in these types of organizations a couple times now, your first 30 days, you're listening, you're building trust, you're getting the lay of the land, you're writing your 30, 60, 90-day plan, you're syndicating it, you're getting folks on board. Then, a company like Brightside is small enough that by the time you've been here for 30 days, like, you know what's going on and there's stuff that needs to be fixed immediately. And so, one of the things that I found to be effective for me is using sort of that time to get into the weeds and model the behaviors that I want my folks to do going forward. And so, to give you a Brightside example, we launched Medicare, 65 days after I joined, and 30 days before launch, as I'd been there for 30 days, it was clear we just didn't have as much cross-functional organizational muscle as I would have liked. And so I jumped in and I ran the punch list and the daily stand up and the spreadsheet of things to do and all of that, for the next 30 days. And we had a successful launch, and I had great help from my team, but I was project managing, as the new COO, and I haven't had to run a punch list since. But it was a great way to kind of get in and, show that I was willing to jump in and get into the details, but also model kind of what my expectation of a leader was, and help my team continue to grow.
And how does the COO job look like on a typical week? How do you allocate your time? What are the KPIs or metrics that you look at every day?
Way too many meetings. I wish I had a lot fewer of them, but I think between doing the cross-functional coordination with my peers on our executive team and then doing one-on-ones with the folks I manage and work closely with, I spend a lot of time in meetings. And I actually, hold myself to a calendar order audit every quarter and say, what do I not need to be in? What can I delegate? How can I carve out those thinking blocks? Because our company is small enough and we're growing and we're dynamic, and I need to be answering questions and doing things myself on a daily basis. And then from a KPI perspective, we talked about clinical outcomes, we talked about timely access. The other two metrics that I look at, and I will say for the record, I don't think they're well-constructed metrics, but I do look at patient NPS on a regular basis, particularly the comments, because, I know the two or three things that if they go wrong, tank NPS, and it can be a good sort of feedback mechanism. And then I'm also focused on employee NPS because, I have a large team, and my team ranges from hourly employees through to kind of senior directors and VPs. And so, again, one of the nice things about being a mental health company is people are here because they believe in the mission, but people are here also because they hope that a mental health company is a great place to work. And so that's something that I am focused on.
What are your favorite frameworks or playbooks that you have learned over the years and that you still stick to, and or maybe you have been adjusting part of those playbooks over time?
Sure. So I'll give you two. So I started my career in a commercial role. I did sales both at early stage startups and then at larger payers. And so One of my favorite frameworks is the sales learning curve, which was put together by Mark Leslie, who was a Silicon Valley executive and who actually taught a class on this at Stanford when I was at the business school there. And it basically says if you think about if you think about the process or of launching a new service line or launching a new company, there's kind of an S shape. And so at the beginning, it's founder led sales and you're learning. You're really at the end of the learning curve, and you need that founder or that consultative salesperson in every client conversation because you're kind of building bespoke. And then as you start to create a repeatable product, you kind of go up the sales learning curve and you can start to move away towards your early kind of hustler sales team. And they're still learning and they're still getting a ton of product feedback, but it's more repeatable. And then sort of at the top of the curve, you get towards the ability to kind of build a sales force at scale. And that's probably a whole nother podcast around how you do that. But that's been a framework that I've used because I've inevitably in my operations roles have taken on some degree of kind of commercial team build out. And so that's been a really good framework. The other framework I use is one that I actually wrote about 5 or 6 years ago when I think a lot of these kind of earlier stage digital health companies were still coming out of stealth, and we were starting to think through what the models look like. And my thesis is that a successful digital health company, really in any chronic condition, brings together content, which is used both for marketing and acquisition, but also as an intervention, community, and that can be text-based, that can be live, that can be virtual, and then clinical care or subclinical care like coaching. And so I kind of, anytime I think about what we're building at Brightside, anytime I look at a company from an advisory, investment, or partnership lens, I'm saying, are they checking the content box? Do they have a way to create community and support patients? And what's their care model? And so that's, the 3 C's of content, community, and care is something that, I'm kind of still developing as a framework, but has been useful.
Have you ever felt helpless in your career? We have all faced
Yeah.
problems like this, many, many, many times. But can you think in a point in time in your career where you felt helpless, and what did you do? What did you learn from it?
Yeah. So going back to my days as a quota carrying consultative salesperson, I lost a couple of RFPs. I had a great success rate, but I lost a couple of big RFPs. And I mean, this was pre-AI, and so we were writing 400-page responses to state, county, health plan RFPs that had been 6 months in the development, and we'd been, done a ton of pre-work, and you write the RFP and you put your pricing out there and you really take your best swing, and then you don't always win. Sometimes you do, sometimes you don't. And when you don't win, it's really easy to say, oh my God, my work wasn't good enough. And I've now been through a number of these procurements. And frankly, I've been on the other side of procurements as a when we're buying technology. And very often it has nothing to do with what was actually in the proposal.
Hmm.
And so I think, learning to take rejection first and foremost, learning to take feedback, because you do get feedback what worked and what didn't work. And then also learning to recognize these are the things that were internal and specific to me or my organization or my proposal. And these are the things that were external. It was a regulatory issue. It was a pricing issue and I couldn't get my pricing any lower. It was a relationship issue. It was something else. And, the second thing I would say is losses aren't permanent. I think I can think of multiple RFPs where we lost and the vendor who won didn't work out and they came back to us. And so I think, just really learning to see the sales cycle as a cycle as opposed to a referendum.
It is a cycle for sure. Okay, so as we wrap up this episode, I want to ask you one final question, and that is like, how do you learn? How do you keep learning? You're busy. You're a COO, growth stage company. You have a life as well outside work. How do you keep up to date and keep learning to continue improving with limited
Yeah.
time?
I mean, I'm a huge believer in, what Carol Dweck writes about in her book Mindset, about the importance of having a growth mindset and to think about skills and knowledge as things that you're continually learning. I consume content. I go on LinkedIn, I listen to tons of podcasts, I read papers, I read journals, I read news articles. Like, I am constantly consuming content, and now increasingly using AI to summarize it for me. And then the other thing, and probably the thing that's most important, is just talking to people. I've had so many people who've been generous with their time as I've kind of built up my career, and it's really important for me to do the same. And so I have my Hiring Friday thing, and I post jobs every week on LinkedIn on Fridays. And then I try to be as generous as I can, especially as a COO, and I've got kids and all that stuff, to people who either want to get into healthcare or who are building a new company. And so I really just try to talk to folks and listen. And I never have a conversation where I don't learn something. And so that's really, and including this one. And so it's really important to just stay connected to folks who are in the industry and doing the work.
Julia, this has been fantastic. And certainly you have been very generous with your time and sharing your experience. So thank you so much. I really appreciate your time and for being here.
Yeah, thanks for the conversation. It was great.
And thanks to everyone else watching and listening. Until the next time.
Sounds great. Thank you.
Bye.